Um, how's the sound? Can everybody hear me?
Yeah.
Okay, good. All right. I'm going to turn it over now to Peter. Thank you so much.
Morning, everyone. My name's Peter Stoner. I'm going to be giving what I call my Medicare 101 presentation this morning, and I wanted to make sure that everybody realizes it's for educational purposes only. So I'm not going to be talking about plan-specific benefits or details, and that's specifically because the federal government, in this case the Center of Medicare and Medicaid Services, CMS, highly regulates this industry, and if this were to be a sales presentation per se, it would have to be scripted, and I would have to follow a script. I find that that is a lot less educational, and I find that if we can go off on tangents, it's a lot more helpful. So I encourage you to ask questions as we go along. As Angela mentioned, we do have this on mute. I'm going to take it off mute from time to time, but it's also my understanding that if you have a question, you can type it in and I can react to it. And again, I encourage you to do exactly that. So the first slide that I have is just for notes. And if you were to print this presentation out and you had 2 slides per page, you would have the notes on the first page. And when I do a presentation, typically I print this out for people. I have 2 sheets per page, and I do that so that they can take notes on the front page and refer to them as they go along. So write that down, and I will answer anything that you have. I'm trying to figure out how to advance this. Okay, so the first slide that I have is I equate Medicare to a maze, and I do that on purpose because, you know, mazes were developed thousands of years ago and they were designed to confuse. Now, I'm not saying that Medicare was specifically designed to confuse, but I will say that that's the end result. You know, politicians got together with lawyers and bureaucrats. They formed committees, and the end result was confusing. Not only that, there's so many rules and regulations that surround Medicare that the average person views it really as a very confusing maze. And I find that when people are aging into Medicare, that is, they're turning 65, they essentially get assaulted with information not only from the federal government, but also from any carrier out there in the market that offers a Medicare Advantage or a Medicare supplement plan. So that it's not uncommon to be 2 months away from your 65th birthday and have about 3 inches worth of literature. And some people actually try to wade in and understand it. And what I find is that they get more and more confused. So when I talk to somebody who's aging into Medicare, frankly, I prefer to talk with someone who hasn't done any research at all, because that means that they're not overly confused, and we can begin with a blank slate, if you will. So first of all, what's my experience? Why would you listen to me in the first place? I have over 22 years of experience in the Medicare market. I started that in 1994 with Tufts Health Plan. In fact, that's where I met Angela Krengle. She was working at Tufts Health Plan at the time as well, focusing on the commercial large groups. And at that time, a lot of the commercial large groups were offering Medicare products to their retirees. So because of that, Angela, I think, for just an example, I believe she represented Verizon at the time. And Verizon had a whole bunch of retirees who were offered Medicare Advantage plans. And I ran the department that would offer those Medicare Advantage plans to the Verizon retirees and do the very large meetings to show the retirees so that if you wanted to join the Tufts product, this is our advantage over the competitors. The interesting thing about doing something in a retiree format is that your competitors are in the room. So, I would get up and I would talk about Tufts, but somebody from Harvard Pilgrim would get up and talk about Harvard Pilgrim. Someone from Fallon would get up and talk about Fallon, and so forth. So what that gave me was an overall picture of the Medicare market that I could never have gotten in an individual plan setting. And later I became the director of Medicare sales for Fallon and Worcester, and subsequently started Stoner and Company, focusing on Medicare in 2013. Now, a lot of times what I do in getting the word out about Medicare is I do lunch and learns and or seminars where I go into companies, and while people who are about to turn 65 or are thinking about retiring eat their lunch, I talk about Medicare. And it's something that I've been doing for a long time at this point, and something, frankly, that I enjoy. So just a little history on Medicare. And the reason that that I like to give history on it is that most people confuse Medicare with Social Security. So they think that Medicare has been around since the 1930s. It hasn't. That's Social Security. Medicare actually started in 1965, and that was because only half the older adults had health insurance, and their coverage was often unavailable or unaffordable to the other half. So, it was determined that the older adults really were getting kind of the short end of the stick. And, I was in high school in 1965. Specifically, I was at the Newton High School that later became known as Newton North High School. But I can remember that Medicare at that point didn't even make my screen. It wasn't really until years later that I thought about it and realized that both of my grandmothers were about 80 years old in 1965. And although one of them was doing okay, one of them clearly wasn't. One of them was just on whatever she was getting in Social Security. So anytime she had a medical expense, that was a big deal for her. So when Medicare came along at that point, it really was a godsend for, in this case, my mother's mother. So at that point, when Medicare started in 1965, the average age or the average life expectancy for a man was 66.8 years old. And I like to point that out because currently I'm 69 years old. So if this were 1965 and I was average, I'd be dead. And I tell that all the time to people because I want to dramatize two things. Number one, people are living longer now than they did back in 1965. That puts a strain on the system. And the other thing that puts the strain on the system is the fact that the baby boomers, people born between 1946 and 1964, are aging into Medicare eligibility at the point of 10,000 people a year. So, part of what's been going on in the Medicare arena for a while has been designed to keep it viable for years to come. So the first thing that people typically ask me when they start to get near 65 is, so how do I sign up for Medicare? Most people know that if they don't sign up for it in a timely fashion, there's a penalty that's associated with that. What they may not know is that penalty is for life. So anytime somebody incurs a penalty for having done something late when it comes to applying for Medicare, that penalty stays for them for the rest of their lives. What a lot of people don't realize, though, is if they're working for a large employer, and in this case, when I say large employer, I'm talking 20 or more employees, and they're on their commercial health plan, they don't need to sign up for Part B of Medicare because they have creditable coverage elsewhere. Now, some people, hear about the penalty and they go ahead and they sign up for it anyhow. And essentially, when they do that, they're paying for something because for Part B, there is a premium. they're paying for something for which they derive no benefit. So I've run across a number of people over the years that have Part B, are still working, are still on a commercial health plan, so they're paying for it for absolutely nothing. So now this next slide is a very important slide. I'd like you to focus on this one, and I'm going to open it up for questions as soon as I'm done with this slide, because I want to make sure that everybody understands this and understands it thoroughly. So people have a 7-month window around their 65th birthday to apply for Medicare Part B. That 3 months starts 3 months before the month in which they turn 65. It includes the month in which they turn 65 and includes 3 months thereafter. So there's your 7 months. 3 months before, the month of, and 3 months after. Now again, that's only if they have to apply for Part B. And if they're working for a larger employer group, they don't have to do that. So the Center of Medicare and Medicaid Services, CMS, requires that somebody fill out a form and submit that form to Social Security in order to apply for Part B. Now you'll see on the slide I say form required and there's an asterisk. Anytime you see an asterisk, that means that I can forward whomever the link to that form. So you can Google it, you can go online and Google it and get it, or you can ask me to forward you the link to the slide, and I'm pleased to do that. But anyhow, on that slide is the form that's required. Once somebody's filled out that form, they can call Social Security, and I have the toll-free number there, and they can apply over the phone, or they can go online at www.ssa.gov. Again, I have the website right there. I find that 20 years ago, people would not go online. Most people who were turning 65 way back when were not comfortable with computers, so that's changed dramatically. The vast majority of people that I deal with now do apply for Medicare Part B online, or they can make an appointment at their nearest Social Security office and go there in person. Some people just like to have someone in front of them that they can talk to. I always tell people, if you're going to go to your nearest Social Security office, call them ahead of time and make an appointment. Otherwise, you're subjected to a very long wait in line, and you can circumvent that line by just making an appointment. I also tell people that if they are applying late for Part B, and by late I mean that they didn't have to apply for it when they were 65, but now for whatever reason they're either losing their employer group coverage or they're deciding to go on a Medicare plan, they're older than 65, they need to fill out CMS form number L564. Again, I can send that to people. And what that does is it supplies a form that you take typically to you, to HR or to benefits, and you then attest to the fact that they've had creditable coverage since they turned 65. So the government is looking, they're dying to find a reason why they can assess a penalty to somebody. But if somebody has had creditable coverage since turning 65, then they cannot be penalized. And the last thing on this slide is once somebody has applied for Part B, so they've already, you automatically get Part A when you turn 65. Now they've gone ahead and they've applied for Part B, so they have both A and B of Medicare. So essentially they do have health coverage, but now they've got to either fill in the gaps of Medicare, which they do through a Medicare supplement plan, which is also called a Medigap plan, or they take the place of Medicare completely with a product called a Medicare Advantage plan. Now I'm going to go into what the differences of those two plans are, but right now I'm going to open it up for questions because I want to make sure that everybody gets, if they have somebody who's turning 65 and or retiring, wants to go on Part B, that they know how to do it. Does anybody have a question?
Literal, do we have to apply for Part B?
I can't hear. I'm sorry. Is there a volume?
Yep.
Wait a minute. We just need to turn up the volume.
We have to apply?
Yes.
You'll still have coverage. If you're still working here, you'll still have coverage. Sorry, it's a question for me.
No, but if I'm not working, we have over 20 employees.
If you're not working, then yes, you would have to.
Okay.
Okay, so I didn't hear that, but it sounds like the question was answered internally.
Yes, thank you.
But I have one more question. So if you continue
Wait,
to
hold,
work,
hold the question just one
age-
sec. We're trying to get the volume up where I mentioned earlier I'm 69 years old and I can't hear. I really
You
can't hear,
continue-
but I can't hear when the volume's too low.
now. So if you continue to work after 65, you don't apply for Part B until you actually decide to retire, and then this Form CMSL 564 would be the form that you would get. Probably still didn't hear it.
Did you hear that?
Not yet. Wait a minute. Try it again.
Okay.
Now I can hear.
So if you continue to work at
Yep.
age 65,
Right?
you don't have to do anything until you decide not to continue working. Is that correct?
Correct. That is correct. Yep.
So
And
then when you decide to stop working
Yep.
and you're older than 65, then you can apply for Part B with this other form, the CMSL 564 form, correct?
That's right. You need to you need two forms if you're over 65. You need the first one
Oh, you need two.
that I talked about, plus you need the 564 form.
Okay, so you need two forms.
That's right.
And if you decide to stop working at age 65, then you have that 90 days on each end of your birthday to apply for Part B.
That's right.
Okay, but Part A is automatic when you turn 65,
It is.
even if you're still working?
Yep. You still have Part A. You have Part A the first of the month in which you turn 65. The only exception to that is if you're born on the first of any given month, then it goes back to the preceding month.
And you don't have to do anything to get Part A?
Nope. I know that
Okay.
a lot of times you do. You don't. You automatically get Part A. And in fact, at that point, your Part A is virtually dormant. It just sort of sits there.
Okay, but you don't have to do anything.
You don't have to do anything. A lot of people do something just because they feel like they have to. And they're certainly welcome to call, but they have Part A whether they know it or not once they turn 65.
Okay. Okay.
Other questions? No, we good?
Okay.
All right.
Well,
So we're going to mute you again. We'll be back. Okay, is this the next slide?
Yeah.
So the next slide has to do with A and B of Medicare. And what does A and B of Medicare cover anyhow? So with Part A, and we've already established you get that automatically. There's no premium associated with that. You get that automatically, and that's particularly if you've worked 40 quarters. So if you've worked 10 years, you've paid into Medicare, you get it automatically. Sometimes people get it through a spouse. But when you have Part A of Medicare, that covers hospitalization. Now, it's got a big gap in that the coverage, in that if you were to be hospitalized and all you had was Medicare, you would incur a hospital deductible of $1,288 in 2016. Now, that's not an annual deductible. That's a per benefit period deductible. And new benefit periods are established once somebody has been discharged from a hospital for 60 or more days. So if somebody is admitted to the hospital in January, for example, and all they had was Medicare A and B, they would incur that deductible of $1,288. And then if they were released and readmitted to the hospital, say in April, they would incur that deductible all over again. And that's the principal reason why, or one of the main reasons why people take either a Medicare supplement plan or a Medicare Advantage plan, because they don't want to incur that, $1,300 deductible for a hospitalization. Now with Part B, there is a premium associated with Part B. So the majority of people who already have Part B pay $104.90 per month for that Part B. When I say the majority, about 70% of the people pay that amount, $104.90. And in 2003, the Medicare Modernization Act came along, and the Deficit Reduction Act in 2005 came along. And what that did for the first time is it applied income benchmarks and means testing to the Part B premium. So what does that mean? That means that people who have adjusted gross income as a single person of $85,000 or $170,000 as a couple, if you make less than that amount, you pay that $104.90 base rate. But if you make more than that, the government charges you more. And in fact, the new charge for people who are brand new to Part B, as of 2016, if they make less than those amounts I just mentioned, they pay $121.80 for Part B. And again, that's adjusted gross income. Adjusted gross income can be found on line 37 of an itemized tax return. And the government looks back 2 years. So if somebody is turning 65 in 2016, or if they're retiring and losing their health coverage in 2016, the government will look back 2 years to their 2014 tax returns. So that's an important point. They're going to look at the 2014 tax returns, and they're going to charge people, in some instances, appreciably more if they made more than that lower income benchmark. So you can see the benchmarks right there on this slide. The highest benchmark is for single people making more than $214,000 of adjusted gross income, or couples making more than $428,000. And in that case, they're being charged almost $400 a month for their Part B. And, that's an important point, because sometimes I run across people who are thinking about going on a Medicare health plan. They work for a small employer, let's say an attorney, for example. The attorney, they've got 10 employees. So the founder is turning 65, and he or she thinks, well, it's probably going to be cheaper for me to go on a Medicare plan. And that very well may be true, but then it becomes a math example. You've got to look at the math, and I do that a lot for people. I look at the math associated with what it would cost them if they were to take a Medicare product. So let's follow this attorney example through for a moment. You've got an attorney, and let's say she made $220,000. She's single. She made $220,000 in 2014. That puts her in the highest bracket. So she'd be charged, let's round it off just for the sake of easy math. She would be paying about $400 a month just for Part B. She would be paying about another $200 a month for a Medicare supplement. In this example, let's pretend she doesn't want a Medicare Advantage plan. I'm going to go into this in more detail, but she doesn't want to deal with an HMO or a network. She wants top of the line Medicare supplement plan. That's going to add another $200. She's going to need to take a Part D plan for prescriptions. Let's say that adds another $35. So now we're up around $635. She's going to be charged extra because of her income also for Part D for about another $70. So she's got about $700 that she's going to be responsible for because she's a high wage earner. So then what I do is I compare that, okay, there's the $700. What would it cost you on your commercial plan? And is your commercial plan a better deal or not? So it's pretty simple at that point. It's either yes or no. But one of the big variables under Medicare is prescriptions. So what I do always is I look at somebody's prescriptions and I look at the Medicare Part D plans, the prescription piece, to see how much their prescriptions would cost, because a lot of times that's the piece that either makes going on Medicare viable or less attractive. So in this case, again, this person has got about $700, but that may bode well when comparing it against what it costs her on a commercial plan. The commercial plans for people who are over 65 are not inexpensive. Lots of times they're associated with co-payments, and more nowadays they're associated with deductibles. And those deductibles can be quite substantial. So on the Medicare example of $700, yes, that's high, but there are no deductibles and there are no copays. So that may compare very favorably with the commercial plan. Not only that, but oftentimes, say this high wage earner is the owner of the company, and they're also the oldest person there. As Angela would tell you, it oftentimes is attractive for employers to get the older person off the census, put them on a Medicare plan. That brings down the average age for everyone else, and now everyone else is paying less, and so is that high wage earner. Now, again, I want to unmute this because there typically are questions associated with this, and I want to see if anybody has a question. Does anybody have a question? You there? I hear something.
Yep. Okay.
If you don't have a question, just say, no, I don't have a question.
Pat?
Can't hear.
Okay. Pat, is there any questions?
Huh.
Okay.
Are there people there?
Yep.
Okay.
Yep.
Okay, so we're going to go to the next one. Well, now we can hear people. I don't know what I did there. So that the next slide is important. Got to get to the next slide. Okay. So we're looking to get to the next slide. The next slide has to do with the health insurance options when somebody turns 65. So there it is. So there are 4 options when somebody turns 65. And the first option is they stay on their employer's health plan. This is particularly true if they've got more than 20 employees. So if you've got more than 20 employees, Medicare is not supposed to be primary, and that has tax implications. However, more and more nowadays, I'm finding even though somebody works for a company that has more than 20 employees, they're choosing to go on Medicare again because of that high deductible. They're tired of paying that high deductible, and so they choose to go on a Medicare plan by themselves. Again, there's not the majority of people that are doing that, but more and more people are doing it. The next option is they just go on Medicare A and B. So when somebody has Medicare Part A, which is the hospitalization, and Part B, which is the doctor visits and so forth, they do have health coverage. You know, they have gaps and so forth, but they do have health coverage. I find that most people that are just on Medicare A and B are typically low-income veterans. And the reason that that is true is because they go to the VA to access their health services. And now, whenever I meet a veteran that has A and B, and that's it, I always encourage them to take a zero premium Medicare Advantage plan just to have in their back pocket. And the reason that I do that is because if somebody is hospitalized and all they have is A and B of Medicare, then they incur that $1,288 hospital deductible that I mentioned earlier. And if somebody is hit by a bus, the ambulance doesn't take them to the nearest VA hospital. The ambulance takes them to the nearest hospital, period. And then they incur that deductible. So if that same person had a zero premium Medicare Advantage plan, then they wouldn't be paying anything, so it would be costing them just as much money. But they would be admitted to the hospital on an emergency basis, and they would pay a copayment for hospitalization, usually somewhere around $350. So that's not to say that it's free, but $350 is a lot cheaper than $1,288. So frankly, whenever I find somebody that fits that category, I consider it a public service to suggest to them that they go on a zero premium Medicare Advantage plan. But clearly, the two options that most people take once they're eligible for Medicare is either option 3, which is a Medicare Advantage plan, that's also known as Part C, or a Medicare supplement plan, and those are also known as Medigap plans because they fill in the gaps left by Medicare. And those types of plans are offered by the health plans that you're accustomed to in Massachusetts. That would be Fallon, Harvard Pilgrim, Tufts, Blue Cross Blue Shield, United Healthcare / AARP. Most of those plans I just mentioned are indigenous to Massachusetts. Most of them are not-for-profit plans. You know, I'm not talking about specific plans here, but I will take a shot at one of these, and you'll have to figure out which one I'm taking a shot at. But one of them advertises more than the rest of them, specifically on television for their Medicare supplement plan. And I would suggest that the premium is higher for that plan because they have to pay for the advertising. So you can figure it out. Watch television on Sunday morning. You'll see which one I'm talking about. I get a lot of requests for that plan because of the fact that it's advertised. I don't represent it, and I don't represent it because, in my opinion, they don't deliver anything that the other plans don't deliver, but they charge a lot more for it. So now on this slide, it gets more into detail, the four options or the last three options that we just talked about. And when I talk about these options, I use myself as an example and my wife because we're both on Medicare. We both have different types of Medicare plans. So it begs the question, why would we take a different type of plan? And in fact, we take it through different companies even. So the least expensive option is if somebody just has A and B of Medicare. I mentioned that before. The people that I find typically that fit that category are low-income veterans. They do have health coverage. They are responsible for that $1,288 deductible. They are responsible for a doctor deductible. And they are also responsible for 20% of physician expenses. Now, 20% doesn't seem like a lot of money, and yet 20% of a lot of money is still a lot of money. I can remember when I was working at Tufts, I was about 50 years old and I had a ruptured appendix. So I wasn't on Medicare at the time. I went to the Newton Wellesley Hospital on an emergency basis, and when all was said and done, I had doctor charges of $25,000. So, you know, I was on a commercial health plan. They paid for everything. I don't think I even had a copayment. I think I had to pay for the telephone, and that was it. But if I were just on Medicare at that point and incurred a $25,000 doctor bill, then the 20% physician expenses alone would have been $1,000. So, 20% again seems like a small percent, but even if it's a small percent, if the number is large, then that percentage is large as well. So then the next option is the Medicare Advantage, also known as a Part C plan. These are usually less expensive than a Medicare supplement plan. They're more expensive than being just on plain Medicare. They inevitably involve a network. So it's either an HMO or a PPO. And anytime you access services on a Medicare Advantage plan, you incur a copayment. So if you go to the doctor, that's a copayment. If you go to a specialist, that's another copayment. Tests, copayment, hospitalization. Hospitalizations are always the largest copayment under Medicare Advantage plan. And you need referrals when you go to specialists. And the specialists that you are referred to are usually within a circle of specialists within a given facility. So my wife is on a Medicare Advantage plan. Her Part D plan, her prescription piece, is built right into that plan, and she pays about $36 a month. So every time she goes to the doctor, she pays a copayment, but she doesn't go to the doctor very often. She takes no prescriptions. Both of her parents lived to be 95 years old, so we figured, in Medicare terms, when she took the Medicare Advantage plan, she was young, she was 65, and we felt that if we were going to take a quote-unquote risk, this was certainly the time to do it, and her health warranted taking a Medicare Advantage plan. So now if she goes to the doctor, she goes to the primary care physician, in this case at the Newton Wellesley Hospital, and if she needs a referral to a specialist, she needs to get a referral from her primary care physician. And that primary care physician will most likely refer her to a specialist at the Newton Wellesley Hospital. That's not assured, but it's likely. But again, low utilizer, doesn't have a family history that warrants a lot of caution. And the good thing is that if she develops something chronic or if she has some sort of disease at some point, we can change her to a plan that gives her more access to doctors every year during the Medicare open enrollment, which is in the fall. So between October 15th and December 7th, every year we can change her to a different type of plan. So that's her. She's about $36 a month, limited access, but again, it's a great plan for her. I'm sort of going to skip over the core plan because that's a Medicare supplement plan. I'm going to talk more about the Medicare supplement Sup 1 plan. That's the Cadillac, if you will. That's the plan that I have. And in that plan, you can go to any doctor in the country who takes Medicare. So in Massachusetts, that's about 96% of all the doctors. You can also go to specialists without a referral. So I don't have any networks that I have to deal with. But between my Medicare supplement plan and my Part D plan, which covers my prescriptions, because with a Medicare supplement plan, you can't get the drugs included. You have to take a separate Part D plan for that. I pay over $200 a month. Now, so that's a big difference between about $35 and about $200. It's about $165, $170 a month difference between those two plans. But now I pay no copays. So it's almost like I'm on an a la carte menu. I pay my price. I have my appetizer, my entree, the dessert. Everything's included. Whereas my wife is on something that's a la carte. She has to pay separately in copays for all of her services. My services are included, but most especially and most importantly for me is that I had cancer when I was 55. So I got a referral from my primary care doctor at the Newton Wellesley Hospital to the Brigham and Women in Boston. I'd done some research. I realized that they had better outcomes in Boston than they did at the Newton Wellesley. So 10 years later, when I turned 65, because of that experience, I wanted to be able to assure access to specialists. I seem to be okay now, but who knows? My mother had lymphoma when she was 64, so there's some family issues as well. So I wanted to be able to assure access to primarily Boston hospitals and Boston doctors, and I can do that through the Medicare supplement plan. So I'm going to open it up again for questions.
Okay, no questions? Okay.
No questions. Okay.
Keep going.
All right. Just going to hit enter. Okay. So we're going to get to the next page very shortly, but I can tell you the next slide deals with that Medicare doesn't cover everything. You know, in the interest of time, I'm going to skip most of this, but what I do want to focus on is a lot of people think that, Medicare covers nursing homes. Medicare does not cover nursing homes. If somebody is going into a nursing home and they're going to spend the rest of their life in a nursing home, that's something completely separate. Medicare will cover someone in a nursing home if they're there for rehab and they're improving. But they do not cover them in nursing homes if somebody's going to be there the rest of their life. So there's a couple of things that people should consider every year if they're on a Medicare Advantage plan and or on a Medicare supplement plan. The thing that I like people to check every year on a Medicare Advantage plan is what is their maximum out-of-pocket expense. Each Medicare Advantage plan has a maximum out-of-pocket expense, and in recent years the health plans have been changing that expense, and people tend to assume it's the same as it was the year before. It might not be. So the lowest out-of-pocket expense that Medicare Advantage plans offers $3,400, and the highest is $6,800, so it's twice as much. So I want people to pay every year attention to what is that maximum out-of-pocket. They want it as low as possible. What is the hospital copay? Because the copay for the hospitalization is always the largest for hospitals, so that's the thing they really need to pay attention to. A lot of times, health plans also change the list of drugs that they cover, and people automatically assume that if a drug was covered one year, it's covered the next. That's not true. It's not necessarily true, I should say. So when people ask me, I check their prescriptions every year to make sure during that annual open enrollment period that their drug plan, their Part D piece, hasn't changed, or it's not going to cost them more the next year. And under a Medicare supplement plan, that's especially true because Medicare supplement plans, you have to take the drugs separately. So I want people to check their drugs every year, because if a company is going to try to make additional profit one year to the next, they tend to work it into the prescription piece, and people tend to go along with it unknowingly. So I'm going to talk a little bit about the prescription coverage under Medicare. This is the piece that's the biggest difference relative to commercial coverage. So one of the things that I've found over the years that every now and then I'll find somebody who's looking at the question, should I go on a Medicare plan or should I stay on a commercial health plan? And commercial health plans all have what's called unlimited prescription coverage. In other words, it doesn't all of a sudden, their copays don't all of a sudden change. Whereas under Medicare Part D, they have what's called the coverage gap or donut hole, where someone can go along paying a certain copay for a certain tiered prescription. Then all of a sudden they've used up their allocation of $3,310 and their copayment spikes, and they want to know what happened. Well, what happened was they used up that money. All of a sudden, they're being charged appreciably more. And so if somebody takes either a lot of prescriptions or expensive prescriptions, I always ask them to let me look at their prescriptions ahead of time so I can see how Medicare treats them. And the biggest thing that people need to do is they need to take a look at the drug piece of their coverage, because that's the biggest variable under Medicare. That's the biggest unknown. So you can define a lot of things ahead of time, but you cannot define somebody's cost of Part D unless you go on the Medicare website. Medicare actually has a terrific website. It's right there, www.medicare.gov. And that's the website that I use when I go on and I look at people's prescriptions. And what I typically do is I generate a report for them. I send them the report, and then I shred and or delete the information, because it is protected health information, but it gives them a good indication of what their drugs are going to cost them under Medicare. People can also go to what's known as a SHINE counselor at senior centers. Now, SHINE stands for Serving the Health Insurance Needs of Elders. They've recently changed that to Serving the Health Insurance Needs of Everyone, because they determined that the word elder was in fact discriminatory. I know I always felt discriminated against when I was called an elder, but so these people will do it for free. We will do it for free, or they can go on and they can do it themselves. But that's the important thing to remember about Medicare Part D right now. What most people get involved in is they look at, okay, is there a deductible, $360? Is there a cap on my prescriptions, $3,310? Those things are all well and good, but they don't mean anything unless you can put in your specific prescriptions and see how they're treated. For example, I have a Part D plan for my prescriptions that has that $360 deductible. But I take generics only. I take 2 generics. They do not trigger that $360 deductible. So although I could look at it and say, oh, gee, there's a $360 deductible, that doesn't apply to me. So what I like people to do is to see how it applies to them. There are currently 21 drug plans offered in Massachusetts. They're very different. If somebody doesn't take drugs when they are first eligible, the government will penalize them for not having taken the drugs. And the reason for that is that they're trying to get everybody taking drugs. Huh?
The drug plan, not the drugs.
The drug plan.
Yeah.
And the reason for that is that people who don't take prescriptions typically wouldn't take a drug plan unless they were forced to do so. So it's insurance. People who don't use it subsidize people who do use it. So the government wants everybody to take it, and so they'll penalize people if they don't. At 1% of the national average, that penalty, so that amounts to about $4 a year, and that penalty stays with them for the rest of their lives. So the next piece, the next slide, what I want people to see on this one is that for the Part D, again, the prescription piece, there are income benchmarks. And for that high wage earner, again, they pay the plan premium, whatever that Part D costs. In addition to, they pay $72.90 to the federal government. So that all goes into the pool for others. But again, that's a lot of money out of pocket. So, I just want to introduce the concept that sometimes it's to somebody's advantage under Part D to pay cash. I'm not going to get involved in that today because we've got limited time. It does get confusing, but I want to introduce the notion that there's strategies involved in virtually everything, and paying cash for prescriptions is sometimes in people's advantage. Now, the federal accounting standards, as HR people, you're probably aware of that FASB 106. That was the Federal Accounting Standard Board requirement that came out in 1995, and this is what forced most of the really large companies all of a sudden to have, if they were covering their retirees' health coverage, they decided not to cover it after 1995, and or a lot of companies decided to move their retirees from a Medicare supplement plan to a Medicare Advantage plan because they were a lot cheaper. And this is something nowadays you virtually don't find any companies that are covering retirees anymore unless they have grandfathered something where they have to do it. So I want to go through the next slides just in the interest of time. But a lot of times when I talk to people, they want to know, so what is the impact of the Affordable Care Act on Medicare? So I had a 70-page synopsis of the Affordable Care Act that I went through and found essentially that the Affordable Care Act is looking to take about $450 billion out of the Medicare program over the next 10 years. And the points in blue are the ones that I thought are worthy of drilling into a little bit. But they're going to take $135.6 billion out of Medicare Advantage Part C payments. So those are the Medicare Advantage plans. So they're saying that over the next 10 years, they're going to reduce their payments to Medicare Advantage plans by $135.6 billion. That will to implement, with the question mark, is I'm wondering if they have the political will to implement it, because they were supposed to have done that this year in 2016, and Congress decided that they weren't going to do it. Some of those things where they're taking away from the higher wage earners, they're claiming they're not going to do that in the future. I don't believe that. I believe that that more and more we're going to be, if you've got more money, you're going to be paying more. And I think that that will follow us, especially with the baby boomers putting that strain on the system. Just some of the takeaways real quick. I want people to realize that with Medicare, things are in a state of flux. They need to stay vigilant. The income benchmarks are real. They're saying that they're probably temporary. Well, I remember when they started the Mass Pike, they said the tolls were going to be temporary. And I would suggest it's a similar kind of temporary. I think Medicare plans will cost more over time. I think there's going to be more cost sharing to people who make more money. Part D premiums are going to increase because the coverage gaps are decreasing. And so I think that the money has to come from somewhere, and I think it'll come from in the form of higher premiums. Tests and durable medical equipment are going to be more scrutinized. The next point is a big one. Lower provider reimbursement, I think, will reduce access to doctors. So they're looking to pay doctors less, and I think doctors over time will revolt, and they just won't see Medicare patients. I said currently 96% of the doctors in Massachusetts take Medicare patients. That's a good percentage. I think it'll remain high, but I don't think it will remain at 96%. Bottom line, I think Medicare is going to remain a good value, especially for those beneficiaries like my grandmother that I mentioned earlier of limited means. The other stuff is just telling you how wonderful I am. I thank you for your time this morning, and I invite any final questions.
A copy of the slides?
Yep, we'll give you a copy of the slides and the recording. I will send all the attendees a copy of this information to post on your website. If other questions do come up as you go through this with various employees, never hesitate to give me a call. If you'd like to arrange for Peter to speak to your employees in a lunch and learn, feel free to contact me and I will forward his contact information. If you have one or two employees that are aging into retirement age and want his contact information, we can connect you with that as well. Due to the success of this discussion, I think we'll also have another webinar when it gets closer to the Medicare open enrollment time in the fall, so there'll be more information to follow on that. But any questions on today's presentation? No. Okay. Well, thank you all very much again for your time. If you have any questions, feel free to contact me. And I also, on behalf of everybody here at Pinnacle and our clients, we want to thank Peter for his time. So thank you all very much. Have a good day. Bye-bye.
Thank you.